Welcome to this webinar on rehabilitation in dementia. We do have 5 speakers from different disciplines, so we will have a good overview. And I want to give the floor virtually to Alison McKean, and she is accompanied by Danielle McDonald's, and they are both from the Scottish Dementia Working Group. Alison, the floor is yours. It's virtual.
Hi everybody and welcome to our session at the Alzheimer Europe conference. We're delighted to be here to talk about the co-design of digital solutions to rehabilitation and dementia, a really exciting partnership project between the Scottish Dementia Working Group and the allied health professionals in Scotland. So my name is Alison McKean and I'm Allied Health Professional Post-Diagnostic Lead at Alzheimer's Scotland. Delighted to be joined by my fellow presenters, Danny MacDonald from the Scottish Dementia Working Group and Claire Martin, occupational therapist from NHS Dumfries and Galloway. And we're here to talk on behalf of the wider team. So we are really passionate and convinced that people living with dementia have a right to rehabilitation. This is a priority for the Scottish Dementia Working Group and for the allied health professionals in Scotland. We are really keen to keep having conversations about rehabilitation in dementia and make sure that this is happening in practice. So when COVID came along, we had to look at new ways to support the delivery of rehabilitation in dementia, focusing on the occupational therapy home-based rehabilitation intervention. So working in partnership and having discussions, we came up with some ideas to look at digital solutions for meeting rehabilitation needs. So the ideas we came up with were around animation and film, and I'm going to hand over to Danny now.
Hello, the message that we want to get across through doing the animation is that dementia does not define me, I define dementia. Initially, when you get a diagnosis, it can be quite overwhelming. It's through contact with dementia advisors and peer support with people who are going through the same thing that allows you to retake control in your life, which is crucially important. At this point, we'll show the animation and then I'll hand over to Claire.
Since my diagnosis, I was diagnosed with vascular dementia at 52. Prior to that, I was having problems because I was a night shift worker and our computer system had changed. And one of my colleagues spent most of the night going through the new computer system with me. And by the morning, I couldn't remember each stage. I went to see a doctor and did the memory tests and had the CT scan and whatnot, but we're told it was vascular dementia. And initially you feel like your world's come to an end. You don't know where you're going to go next. You don't know what life holds for you. But certainly when I got my diagnosis and since then, there's periods where there's a bit of role reversal. Instead of being the parent and the child, they're looking after me sometimes. They've dealt with it very well. It's in lots of ways it's been a positive experience. So since diagnosis, my wife phoned Alzheimer's Scotland. The dementia advisor came along to our house and spent quite a bit of time with us and quite a lot of literature. We're very fortunate living in Clydebank. We've got a local dementia centre right on our doorstep. There's so many activities that's available with Alzheimer's Scotland. We go to the choir, which is a Every Voice community choir, which is for everyone, but it's inclusive of people with dementia. We go to a supper club once a month where we have a meal together and a chat. I go to a day centre twice a week, and there's various drop-ins that you can go to as well. There is an allotment. I'm not really a gardener. I take my ukulele when people are gardening. We've made a lot of really good friends, and some of whom we socialise with, out with. I don't think about the future too much. At the age I'm at just now, I could live another 20 years. Conversely, I could live another 5 years. You don't know, you make the most of today. You go with the flow.
Thank you, Danny. That was great. And here I'm going to talk a bit about my experience of animation. The key to success has been using the software and all the different aspects of it. So we found that we have blocks of images, short films that we can use, and there's also a function where we can move from text to speech to add in a voiceover, and we can also add in subtitles. So that's helped us animate different memory strategies, and I'm going to show you one that we produced on keys. So here we have a cover that we're going to use for each of the animations, and then we go in to explain about the importance of keeping your keys in the same location and getting into a habit that fits your home. And we've found it useful to have the blocks of images that we can add together. So we're getting comments from people about those different animations, which is also helpful for us. And I'll now hand over to Alison.
Thanks, Claire. And I want to talk about a fantastic film that was produced in partnership with the Scottish Dementia Working Group, where Henry, Lorna, Ian, and Margaret are sharing talking about rehabilitation and sharing how they use their strengths and abilities on a daily basis. Some fantastic advice. I've only got time to show a very short clip of the film, and I'm sure you'll really enjoy it.
I fully understand the meaning of rehabilitation, and I think it applies to anyone, no matter what they've got, you know.
When you're talking about rehabilitation, it's like just learning new ways to cope with having dementia. I think the thing that's helped me the most is actually the iPad. I do jigsaws on my iPad every single day, and it's so easy to use, and it keeps your brain working away there, and it also passes the time. And it's just getting into the habit of sitting down and doing the same things, because to me that's really important. Try and get wee systems that you do the same things over and over again, and it becomes habit. And I think it's a big help in stopping you forgetting things.
Some fantastic advice shared in that video, including keeping in habits and routines, learning new things, challenging yourself. It's so important to learn from the expertise of people living with dementia and to hear from peers as well. One of I love this photo. It just shows what a wonderful sense of humour, how important that is, staying social. I think everybody's having a good laugh there because Henry had suggested that we all go to the pub. It was just a lovely film to make and aligned so well with the home-based memory rehabilitation work. So looking forward to sharing more. So next steps, as we said, we've been creating and testing animations and films. We're currently sharing them and evaluating them and gathering feedback, and certainly seeing the benefits and looking at incorporating this into the work around rehabilitation in dementia.
So the key messages we share with you are that film and animation have a great role to play in supporting rehabilitation in dementia. It allows the person living with dementia to have control over when they access the material. They can choose the time of day that suits them. The person can replay the animation or film as often as they wish. And we've found that using images as well as spoken or written words can help reinforce key messages and make the information more accessible. And there's an added benefit in that the images can be personalised to the individual's own home and items in their house. You know, if it was memory strategies for a specific person, it could show them, you know, where they keep their house keys and what the plan is for them. So there's lots of benefits there. And I'd now like to hand over to Danny.
Yep, the key message that we'd like to the viewer is that the core to the co-design process was that all the team members were recognising each other's expertise, learning outcomes, and having fun together. They produced positive outcomes. And I think the key phrase there is having fun together. I hadn't been involved in doing an animation before, and it's been very interesting, and also it's been fun as well. One of the things I've learned over the last few years since getting my diagnosis is to play the ukulele, and the wee snippet there was of me playing and singing. I hope you enjoyed it. Thank you very much for watching this. Thank you.
Thank you so much for this really impressive presentation. Well, there might be a lot of questions now, but due to the time constraints, I want to give the floor to everyone. And we had a little opportunity before, so I would suggest that we move on to Nikolas Dietzel from Germany. And he is a political scientist by training. And he is going to talk about the differences in assessment of the relevance of support services. So the floor is yours. You are the only live speaker.
Yes, thank you very much for the kind introduction. I hope I'm well understandable acoustically. Okay, perfect. As mentioned, I want to present you the results of my research issue, which is an analysis of the differences in the assessment of the relevance of support services between family caregivers and professional dementia experts. And first, take a look at my agenda. First of all, I want to introduce the project Digital Dementia Registry Bavaria, or short digiDEM Bayern, in which this specific research question took place. And afterwards, I want to talk about the specific elements of the research question that was mentioned before. For the background, there are currently about 70% of the people with dementia in Germany that live in their home environment and are cared for by close relatives. And due to the care and the care process, family caregivers often suffer a high caregiver burden, which can ultimately lead to family caregivers becoming the so-called invisible second patient. That means that due to the care and caregiver burden, family caregivers can become sick themselves. In Germany, there is a range of support services that can provide relief for family caregivers, but in order to provide an efficient and sustainable healthcare planning, it's important to know or to have knowledge about the assessment of support services by the service users themselves. And therefore, we were developing the research issue, which is, as mentioned before, an analysis of potential differences in the assessment of relevant support services between the service users on the one hand, so the family caregivers, and professional dementia experts on the other hand, which are predominantly the service providers. The project Digital Dementia Registry Bavaria is funded by the Bavarian State Ministry of Health and Care and part of the Bavarian Dementia Strategy, which was founded in 2013. And the project is based upon two pillars. One pillar is the setup of a digital registry in order to collect longitudinal data about the disease and disease progression, but also in particular about the care situation of people with dementia and their family caregivers. and the data collection process will take place in the 3 years follow-up period. And the second pillar of digiDEM Bayern is the development and provision of digital services in order to actively contribute to the improvement of the care situation. So the first step for inclusion of participants in the project is a screening with the 2 tests, mini mental state examination and Montreal cognitive assessment. And in case a participant meets the inclusion criteria, there will be interviews at baseline and afterwards after 6, 12, 24, and 36 months. So here you can see the inclusion and exclusion criteria. Our target group are people in an early or beginning stage of the disease. So we are including people with MMSE score of 15 to 23 points. And in case the MMSE score is higher than 23 points, there will be an additional performance of the MoCA test, and people with a MoCA result of 0 to 23 points will be included in the project as well. So further inclusion criteria are that the participants live in their home environment and have their primary residence in Bavaria. And apart from that, we are including all types of dementia according to ICD-10 classification and all age groups. Recruitment of participants will take place in all administrative regions of Bavaria. On the right side, you can see a map of Bavaria showing the heterogeneity of the state. In the next 20 years, predominantly the northern regions, northern parts of Bavaria will experience a strong population decline. The regions in the southern part will predominantly experience a population increase accompanied by differences in demographic and socio-economic characteristics. And therefore, it's highly important for us in the project to reach and recruit people from all the different places in Bavaria, and in particular from rural as well as urban regions. So, and the recruitment itself and the interviews are performed by research partners. And research partners are facilities that work in the field of dementia and dementia care, like community counseling, memory clinics, or daycare facilities, to only name a few examples. So here you can see an overview about the data we will collect in the project and the research instruments that are used for collecting the data. And for the current research question I'm presenting today, the data in the red box is important because we are collecting data about the needs for and use of services. And in order to do so, we were developing a research instrument called Dementia Assessment of Service Needs. And the instrument was developed by means of a focus group and an online survey. And the online survey is also the fundament for answering the research question I'm presenting right now. So it was an anonymous data collection. Participants were asked to provide information on gender, background, and years of experience in dementia care. And afterwards, participants were required to perform a rating of 44 different support services according to their relevance for dementia care. And those support services were identified in the focus group prior to the online survey. And on the right side, you can see a screenshot of this online survey, which is in German. So we provided the different support services, including a short explanation of the important characteristics of the support services. And then people could rate those services on a scale from 1 unimportant to 10 highly important. And statistical analysis of group differences was performed using t-tests. So, and now I come to the results. First of all, the demographic characteristics. As you can see, there was an approximately equal distribution of participants between the group of family caregivers and professional dementia experts. In both groups, participants were predominantly female. As expected, experience was highly different, with professional dementia experts having an average experience of about 20 years in dementia care, and family caregivers had an average experience of about 6 years in dementia care. And also there were slightly differences in the average assessment of the relevance of support services, with professional dementia experts having an average assessment of 7.73 points compared to family caregivers with 7.58 points. And in both groups, the service with the highest rating, so the most relevant support service, was the general practitioner with more than 9 points rating. So this is an overview about the 15 support services with the highest rating. I want to talk specifically about the 4 services in the red boxes, because those were the services where we could detect significant differences in the rating. And those 4 services were acquisition of aids, outpatient care, services for support in everyday life, as well as family support group, respectively self-help group. And as you can see, the difference in all those 4 support services was more than 1 point, with a moderate effect size according to Cohen's D. And what is also quite outstanding here is that in 3 of the 4 support services, the rating of the professional dementia experts was higher than the rating of the group of family caregivers. So before coming to the discussion, I want to show you the limitations of this study. The study population was not exclusively, but predominantly from Bavaria, which limits, of course, the external validity of the study. And due to the recruitment process, there is a potential selection bias of participants, as it was no random sampling. And now to the discussion. According to international literature, utilization rates of support services are low, despite in many studies there is a range of offered care services, and our research can provide a further explanation for those low utilization rates, as results indicate there could be a mismatch between demanded and offered services. There are further factors discussed for explaining low utilization rates, like a lack of knowledge about services themselves and in particular their availability, and a lack of orientation in the service landscape. And another important aspect from my point of view from our results is that family caregivers rated most support services as less important than the professional dementia experts. In particular, if you take a look at the 4 services I presented before. And that also goes along with international literature showing that often family caregivers underrate their own need of support services, even in case there is a high caregiver burden. So, and finally, my take-home message, external support services are important measures for effectively reducing caregiver burden. But in order to provide an effective and sustainable healthcare planning, it's quite important to address the specific needs of people with dementia and their family caregivers, and to also frequently include the feedback according to the offered services. Because by doing so, supply gaps can be identified and transformed into specific regional healthcare policy. And the provision of data in particular according to the needs of people with dementia and their family caregivers for healthcare planning is also a central aim of the project digiDEM Bayern I presented you before. Thank you very much.
Thank you very much, Nikolas. And it's good that you show your address here because due to the time constraints, we can't take questions now. And well, I would like to ask you to send the questions directly to this address. Thank you very much.
Yes, thank you.
And now I want to move to the 3rd presentation of Trish O'Sullivan from Ireland. It's a pre-recorded presentation on education and training to support physiotherapists working in dementia care.
Hello, my name is Trish O'Sullivan. I'm a doctoral candidate here in the University College Cork in Ireland. I also am a physiotherapist and I'm working currently in the role as practice education coordinator. I'm going to speak today about the development, delivery and evaluation of an educational intervention to support physiotherapists caring for people with dementia. I'm very lucky to have a very experienced supervisory team. There's Dr. Joseph McVeigh, who's the head of discipline of physiotherapy here in the University College Cork. Also Dr. Tony Foley, who's a GP and lecturer in general practice in University College Cork. He also has a research interest in dementia care and primary care and curriculum development. And finally, Professor Suzanne Timmins, who's a consultant geriatrician and is the National Clinical Lead on Dementia in Ireland. So just a bit of background on this PhD. So, there is no doubt that dementia is one of the greatest social and healthcare challenges of our time. And the consequences for the person living with dementia are profound because it's associated with impairment in both physical and functional ability. And with a growing aging population internationally, there is an increased demand on healthcare professionals to have the appropriate knowledge, skills, and competency in dementia care management. Physiotherapy has a key role to play in the caring for the person with dementia in lots of aspects of dementia care, for example, falls risk assessment, maintenance of mobility, strength and balance training, post-fracture rehab. So again, physiotherapy has a key role to play. So my interest in dementia and working with dementia really grew out of the Prepared project. This was a project that was based here in University College Cork. It stands for Primary Care Education Pathway and Research in Dementia. We actually presented our findings of this project in the Alzheimer Europe conference in 2018. So the overall aim of Prepared was to develop, deliver and evaluate an educational intervention for primary care clinicians. And out of this study and out of this project, we did a qualitative study that looked at the dementia care experiences and educational needs of physiotherapists in the Republic of Ireland. And what was very interesting from that study was that physiotherapists reported that although they carried quite a high caseload of people with dementia, they had received very little formal undergraduate or postgraduate training in the area of dementia. So that to me established a very clear research gap. So the aim of this PhD is to develop and deliver and evaluate an educational intervention to support physiotherapists caring for dementia. So today I'm just going to talk about the first component of my PhD, which is the scoping review that I'm currently undertaking. And what we're looking at here is knowledge and what type of knowledge that we need to look at, and how knowledge translation really has to go beyond the actual dissemination of knowledge to the actual use of knowledge. So the objectives of this scoping review is firstly to identify studies that have evaluated physiotherapy dementia educational interventions, and then to critically appraise these studies, and then finally to use these studies in the review to inform the design and delivery of a dementia educational program for physiotherapists. We published the protocol in January of this year, January 2021, in the HRP Open Research. So I'm following the Joanna Briggs Institute methodology for scoping review, which follows the PCC concept, which is population, concept, and context. So what I've included is studies that include dementia education or training for both student and qualified physiotherapists. Concept, and again, we're looking at knowledge translation, going beyond actual dissemination, as I said, to the actual use of knowledge. And here I'm going to be guided by the expert group, which is the EPOC, which is the Cochrane Effective Practice and Organisation of Care group, which reviews the effects of knowledge translation activities. So I'm going to be guided by EPOC here. And also the context. So I want to establish the breadth of the literature that's available. So I looked at acute, primary care, and the long-term care settings. So this is just a quick snapshot of my Prisma flow diagram. So those 281 records that were assessed for eligibility for title and abstract. So this was done by both myself and another author, and that this was done blindly. And from there, we excluded 260 reports. And for the most part, it was because physiotherapy was not represented within the educational intervention within the participants. So we did allow for interprofessional educational interventions within which physiotherapy was represented. Other reasons why reports were excluded because they weren't specific to dementia training, or it didn't look at an intervention it didn't look at an actual intervention. So there was 21 papers reviewed for full text, and out of that we've included 11 papers in the scoping review. So just some results that have come in regarding firstly study characteristics. So for the most part, the studies were simple observational pre-post study design. There was one mixed method study and there was one exploratory study. So the population, so for the most part, it was, healthcare professionals across different sectors in both acute and primary care, within which physiotherapists represented 187 of 1,633 AHPs. So again, which is quite a small number. Again, we had over half of the studies were based in an acute hospital environment, and there was one in primary care, and there was four in an educational setting. So the content of the intervention was informed by literature reviews. So 6 studies underwent a lit review to guide the intervention. Some studies did an educational needs analysis of participants. Also guidelines, both national and international guidelines guided 2 studies, and 2 studies also looked at learning models. So for example, the Biggs constructive alignment in the context of work-based learning, or experiential learning theory that looks at a focus on learning in action. So with regard to the content and delivery of the educational intervention, for the most part, it was a blended learning that was used by most studies. The modes of delivery included didactic. A lot of studies included, PowerPoint presentation, lectures. There was group work, which went hand in hand with case-based discussions, where a group of participants were given a case, and they had to discuss and come up with management options and plans. There was 2 studies that looked at virtual reality, and this was very interesting. And one particular study created a resource that augmented a virtual environment and gave the student an insight on what it would be like to live with dementia. There was also face-to-face patient interaction, and there was also simulated patients in one study, and also one study included a reflective component. So the actual content of the educational intervention was not specified in many studies, but where it was specified, it did include strategies to improve communication, ways to manage challenging behaviour, the impact of the acute hospital environment was covered, management of complex cases, so maybe a crisis admission post-fall or post-fracture, delirium was covered, as well as medication and post-diagnostic care. So I've used the Kirkpatrick framework of training evaluation, which is widely used in the healthcare setting to evaluate an educational intervention. So it looks at 4 levels. The level 1 being reaction. So how did the actual participant feel about the training program? Satisfaction. Level 2 would be learning. So to what extent do the participants improve knowledge and skills and attitudes as a result of the training? Level 3 is behavior. So to what extent did participants change their behavior because of the training? And then level 4 is results. So this is really looking at patients, because of the training of the healthcare professional, because of the training of the physiotherapist, how did this improve patient outcome? So looking here, 7 studies reached the level of learning. I'm looking at knowledge and confidence. So that would be level 2, and 2 studies reached the level of knowledge. Okay, knowledge alone, they did not look at confidence. So that again is Kirkpatrick level 2. And there was 3 studies that reached the level of behavior. So because of the education intervention, their behaviors changed in the workplace as a result of the training. So the effects of the intervention. So for the most part, a lot of the studies looked at knowledge and confidence. And for the majority of studies, the knowledge in 6 studies, it showed an improvement in knowledge immediately post-educational intervention. And in confidence, it showed 8 studies showed an improvement in confidence. There was some studies that looked at just immediately pre and post, and then there was some other studies that looked at a 4-month and a 6-month follow-up. So what components had the most impact? So had the most impact on learning. So direct patient contact was one that had a very positive learning experience for the participants. Where patients thought components of the intervention was also very impactful, the virtual reality component, and also the group work, focusing on case-based discussions. So I'm still at the scope review stage of this PhD. The next step for me is going to look at a mapping exercise that looks at the undergraduate and postgraduate training available for dementia in Ireland and the UK. And then I will go on to some focus groups of physiotherapists, patients and carers. And this all will hopefully help guide the pilot of the educational intervention. And just a final thought, I worked 13 years clinically in the area of neurorehabilitation, and I would have cared for people with dementia every day of my clinical career when I worked, especially in the hospital setting and also in the primary care setting. And I'm hoping that this research will hopefully develop an educational intervention that will help upskill physiotherapists and to ensure optimal patient care for the person with dementia. Thank you.
Thank you so much, Tricia. Well, unfortunately, you are in place, but we don't have time for questions. But I think it's very important to first study whether a training is effective for those who receive the training, instead of immediately jumping to the effect of training on patients. Thank you so much for this.
No problem, thank you.
And now we are going to move to the next presentation by Emma O'Brien, who is also present here, but it's also a pre-recorded presentation. And it's especially about the contribution and value to people with dementia of memory technology resource rooms training.
Hi, and welcome to the Memory Technology Resource Room presentation. My name is Emma O'Brien. I'm an occupational therapist and a clinical lead for the Memory Technology Resource Rooms in Ireland. So an overview of this presentation, I'm going to introduce to you the Memory Technology Resource Rooms service that we offer and some background into that. I'll then provide you with some of the findings of the evaluation of service, which was produced a report in 2020. And then finally, just end with some comments and the future of the Memory Technology Resource Rooms. So first, to introduce them. So the service, it's an innovative post-diagnostic service and support. It is for people living with dementia, for people with other cognitive impairments, for family members, for carers, and for healthcare workers. The service is facilitated and managed by an occupational therapist and is a 2-day-a-week service at this time. The primary objective of the resource rooms is to demonstrate a wide range of assistive technology. It's to provide practical resources and advice, and to build education and awareness. Very quickly, a bit about the background and development. So in 2013, there was some funding made available in Ireland to develop post-diagnostic community support services for people with dementia. One key aspect was to develop and trial an assistive technology service. In Tipperary, the Memory Technology Library was built and established, and this was really to demonstrate the wide range of assistive technologies and provide practical advice and assessment on those from an occupational therapist. This service then became well established and became then the blueprint, the template for the development and establishment of the National Memory Technology Resource Rooms, which were launched in 2018. So there are now 30 memory technology resource rooms throughout the country of Ireland. And I'm just going to give you some information about the assistive technology now that we would demonstrate in the service. So it ranges from very simple orientation products and devices to more high-tech GPS monitoring technologies. There's a wide range of different technologies that are out there that we demonstrate. And some images here that we might have on display. So there was phones, clocks, remotes, medication dispensers, one-button radios. And again, all of these are on demonstration and they're live, they're plugged in, they're working, they're announcing, they're reminders, whatever the piece does, they're on and active for people to see. One of the critical things we must do as occupational therapists is to identify new technologies and then to evaluate them to see functionally and technically the aspects and how they work. This begins from basic setup and understanding how easy is that to do or how difficult it might be to do and who needs support in that. Then we look at the requirements of that piece of technology and we practically work through that, and we really identify down to if it requires a plug, and will this affect where it's placed. We look then at the considerations, and we use a lot of our clinical reasoning then to understand the impact this technology might have on somebody with a memory or cognitive impairment. Other responsibilities of that piece of technology, the prompting to use it, the establishing it into a good routine, the ongoing cost, the charging, whatever it may need, we consider that and identify that also. And we've really focused a lot on the ethical implications of the more high-tech technologies. So, we've created some good supportive literature or handouts for people to support decision-making here. All of this information comes together then toward a nice product information sheet that gives the visitor, the person with dementia, the family member, the healthcare worker, really good advice then about the value of this piece of technology, the considerations you need to take, where you can buy it, how much it is. And so we have a nice product information sheet then on each piece of technology. These are just some images of how we might demonstrate and what might be on display at the memory resource rooms. It's a snippet. We have quite a lot, but you can see how they might be categorized from orientation, clocks, phones, medication, remotes, simple home technologies, and smart home technologies. We do a lot around non-technological interventions, of course, we do as well. We talk a lot around practical strategies, around building routines, around diaries maybe, or prompts. We do a lot on education and advice and provide insights into behavioural changes, changes in the sensory system, advice around environments, and we would give a lot of advice then around ways to keep active and stimulated. We demonstrate equally a large range of activities to give people ideas of what they can be doing to keep well and to keep stimulated. We signpost to local and community services and supports. Some memory technology resource rooms are offering some group work. We hope that develops for all. This might be post-diagnostic memory groups. Some offer social groups. And then we would always encourage everyone to, come back if they need in the future or to get in touch again. So repeat visits are really encouraged. The Memory Technology Library is really a non-clinical and homely setting. It's nice and warm, and we avoid heavy assessment. We try to keep it informal and person-centered, so gathering what the issues are for that person and look at the strengths that they have. That leads then to the demonstration of a piece of technology that might be suited to compensate for that, for the issue the person is experiencing. In some cases, we can loan technology, and this gives people the chance to take it home for a month and trial it, and allows them to see if it's valuable and worth them investing in it. We provide practical advice and strategies always as well for the piece of technology or for keeping well. And of course, we have plenty of resources that we have for national and local services that we provide also. So the evaluation of the memory resource rooms was done in 2019 by Kevin Cullen, who is an independent researcher. And the aim really was to gather information that would document, I suppose, the value of the memory technology resource rooms and the impact that they're having. There were three elements to it that we wanted to look at, and that was really to gather, to collect the data that's typically gathered, but to collate that about referrals and demographics. Then we wanted to look closely at profiling the resource room. So what was the service offering? What were visits like? What would have been discussed? And then we wanted to gain some feedback from the visitors and clients of the service and get their take on the memory technology resource room. So in 2019, there was 25 resource rooms set up, and there was a total of 2,261 referrals that came in that year, of which 1,875 received an appointment. And that's just some of the, some people didn't have a diagnosis of dementia, which is no problem. And you can see that just under 60% would have had a diagnosis. The source of the referral then would be typically the community, the secondary services, so like the geriatricians, the memory clinics, the acute setting. And 13% of the referrals were self-referral, which is good, and we hope that that would increase in the future. The types of appointment were pretty much mostly around technology demonstration. That might have been the primary piece of the appointment. Often non-assistive technology advice would be given, signposting to other services, and in some very small cases at the time we were loaning technologies. And then the types of assistive technologies demonstrated, it's often orientation tends to be the most that is given demonstration, and then communication, telecare, prompts, reminders, safety, fall detectors, and so on would have been demonstrated also. And then non-assistive technology really would have been more around keeping good routines, some memory strategies, carer support. So the feedback was very positive, overwhelmingly very positive. Majority found it a very useful service, which is very good. 98% of the visitors found technology that would might be useful to them. So maybe not now, but to know about them was beneficial. And just some of the comments I've put up, but it was really around a good environment and able to discuss the anxieties that they had. And just the opportunity to be listened and to learn information as well. So a small number of the resource rooms would have had a follow-up phone call, just 34, just for this purpose of this evaluation. And 66% had said they went on to acquire assistive technology, of which orientation clocks were the most common. So the concluding comments. The contribution really, so they're making an important contribution to the achievement of our national dementia strategy. They are an important addition to dementia care pathways and to post-diagnostic supports. And in addition to the expert assistive technology advice that is provided, it's the guidance and advice on broader aspects of living well with dementia. And just a quick note on the memory technology resource rooms, our network. So each member of the resource rooms is part of the group, and we meet 4 times a year. We develop policy and guidelines. We're building our evidence-based practice. We provide opportunities for training and learning, and there's great peer support and sharing of knowledge. And there are several subgroups that work on focus development. So the future really is to look at sustainability and growth of the memory technology resource rooms, to develop research to strengthen our network that supports the operations. So thanks for listening. More information can be found at the links there, and you can email me if you need any more information. Thank you.
Thank you so much, Emma, for this very useful overview. And I think it's especially useful that you help people to select between the huge offer of
Yes.
assistive technology, and that you also look at the how you can facilitate the use. Unfortunately, due to constraints, we can't have a discussion. You
No.
already gave your email address, but I want to ask every speaker to give their email address in the chat function so that people are able to pose questions afterwards. Thank you so much, Emma.
Thank you.
And now we are moving to the last speaker, Lisa Cronin from Ireland, and she's also present, and she has a pre-recorded presentation. She has a master's in dementia studies and in Cork in Ireland, and she's a dietitian by training.
Good morning, everyone. My name is Lisa Cronin, and I'm delighted to be here today to present my research study to you. The title of my research is Accessing Specialist Palliative Care for People with Dementia. I completed this as part of a master's degree in dementia in University College Cork in Ireland in 2021. Firstly, a bit of background. As in many countries, the population of Ireland is aging, leading to an increase in dementia diagnosis. As we know, dementia is a syndrome characterized by progressive cognitive impairment and is associated with impairment in functional abilities. And this is from the National Dementia Strategy in 2014 in Ireland. So how does this fit in with specialist palliative care? I thought firstly we would define palliative care. According to the European Association for Palliative Care, it is the active, total care of patients whose disease is not responsive to curative treatment. It is interdisciplinary in its approach and encompasses the care of the patient and their family, and should be available in any location, including hospital, hospice, and community. Palliative care affirms life and regards dying as a normal process. It neither hastens nor postpones death and sets out to preserve the best possible quality of life. So how do these two definitions meet? Evidence suggests that people with dementia benefit from specialist palliative care input, and this was shown in a literature review conducted by Hansen et al. In 2019. It focused on creating an understanding of dementia care and family caregiving associated with the trajectory of the dementia journey. There is a need for more understanding and recognition of advanced dementia and the extended palliative care phase. There was no accepted definition of advanced dementia within the literature, and where it was defined, most experts agreed that a palliative care approach was at the advanced stage of the dementia illness. There is little known about implementing a palliative care approach at the earlier stages. A palliative approach is an appropriate model of care for people with dementia. However, the authors noted that there was often a lack of specialist palliative care involvement for people with dementia. This was attributed to a lack of understanding of advanced dementia among professionals and a reluctance to refer to specialist palliative care services, given the fluctuating disease trajectory for many people with dementia. It is not the same as a disease trajectory for those with a malignancy. And this was also recognized in a study conducted by Ryan et al. In 2011. A Delphi study by Van der Steen et al. In 2014 suggested more research has to be completed to enable a clearer understanding of what care is appropriate across the various stages of the dementia disease journey. There was no clear unanimity from the experts as to what stages of dementia palliative care can most apply to. However, there was an inclination for agreement that a palliative approach is applicable in all stages. So what was the aim of this study? It was to explore how people with dementia access specialist palliative care services from the perspectives of the healthcare professionals involved in the referral process. And my methods? My design was a qualitative design. I used a semi-structured interview method with open-ended questions, and the intention was to create a relaxed atmosphere with participants to encourage and engage with conversation whilst discussing the topics that were outlined in the interview schedule. The target population was healthcare professionals who were involved in the coordination and or provision of dementia and palliative care. And the setting was a large working hospice and residential care facility in the Midwest region of Ireland. I had 10 participants, and these included clinical nurse managers, specialist palliative care consultants, specialist registrars, and assistant director of nursing. And for my data analysis, I used thematic analysis. And this is a method for identifying, analysing, and reporting patterns or themes within the data. It organises and describes the data set, and it can interpret various aspects of the research topic. And this is according to Braun and Clark in 2006. So I found this very useful and very appropriate. So I had 4 key themes in my results, and we'll go through each of these in the following slides. Capacity for providing dementia-specific specialist palliative care. A common premise highlighted by most interviewees was that specialist palliative care services typically do not provide the same quality of dementia care as a specific dementia unit. Participants noted that while specialist palliative care services do and should have a role in caring for people with dementia, those with dementia tend to be older and have more comorbidities. And this is reflected in participants 1. I suppose the difficulty is that when you deal with nursing and medicine, whatever it is, whether you are in a stroke ward or whether you are in a neurosurgical or a gastro, you meet dementia patients. Some focus from the data was on the infrastructure and resources needed for people with dementia to provide optimal care as needed. The interviewees noted that the actual building, facilities and physical environment is not optimized according to the needs of people with dementia. This was highlighted by participant 6. But I suppose you hear a lot about the dementia unit that are very specifically built to meet the needs of people with cognitive impairment. Specific colour schemes, red doors for the bathroom, familiar objects and things from throughout their lives, and a kind of whole ethos of care. The next theme is appropriate referrals and recognising need. So there is a needs assessment for people referred for specialist palliative care input. And this is very important in providing appropriate specialist palliative care input. This indicates a more focused approach for the right care at the right time for the right person. And not all referrals are in this bracket. Some referrals fit into a grey category within the eligibility criteria, and some, unfortunately, do not meet the eligibility criteria. For example, referrals are sometimes made based on the respite needs of the family or the caregiver, which is not an appropriate use of specialist palliative care services. And this is highlighted here by participant 7. I think any patient, including patients with dementia, if they meet the criteria for admission, will present them to the multidisciplinary team in addition to community services. The data from the interviewees expresses that input for dementia patients may be at different points in time throughout their journey rather than at a continuous or specific point in time. And this, again, is related to the disease trajectory of the person with dementia. And this is indicated here by participant 6. So it might be a dip in and dip out, but it might be that everything that's needed to be done is done at that visit. And the specialist palliative care team may or may not be involved again. Say if that person deteriorates and starts to die and is having particularly complex symptoms. So I suppose it's not so much an access issue, it's more that the model of care might be a little different to best meet these people's needs. Inadequate and inequitable geographical distribution of services. So it's one thing being diagnosed with dementia or any other life-limiting condition, but where do people with dementia and their families and caregivers go for information or services? This concern was highlighted in the data. Even if the information is available in the person's locality, are there enough services available? Are they easily accessible to people? The data suggests that this is a problem and the services do not meet the need at present, and this is highlighted by participant 1. But even community-based services aren't enough, and that's just a reflection of the health service and the community services that we live in. I think they have gotten better, but we do have a long way to go, you know. And if the services are not available for people with dementia and their families, or the services are unknown, it may not have a direct impact on specialist palliative care services, but can directly impact on people with dementia and their families and caregivers, as highlighted here by participant 3. No, it's one of the biggest things out there, but the resources are shocking and it's so limited, and it's going to lead to things like cancer and heart disease. Dementia is going to be. I think you can live in the community with the proper resources and supports with it and live well. I think you can live well. Families are just very much left on their own. And I think this last sentence is very poignant here. Service integration and interprofessional collaboration. Another key theme arising from this data is a clear drive to integrated working. Integrated working is to supplement another part of care rather than replace, which is very important for the patient, as one person or one team cannot be the expert in everything. So this is highlighted here by participant 3. I suppose the challenge is now with all the medical interventions, just even the care, where does specialist palliative care even fit in a person's illness journey? And another quote that I thought was very important in highlighting the right care for the right people at the right time, but also in reach to specialist dementia units. And we have certainly found over the years that actually the staff on the ground there, the nursing staff, the medical staff, the social workers, they've actually upskilled in terms of their specialist palliative care knowledge. It has transpired that we, specialist palliative care, are called in when things are getting particularly complicated, but they wouldn't be looking for their patients to be transferred into our inpatient unit, and nor would we be looking to transfer people. So support them, support the staff and families in those settings. So there's a big element here in outreach. The limitations were, it's a small sample size, it was in one geographical location, and initially I was hoping to carry out some quantitative data collection, but this did not meet GDPR and therefore could not get ethical approval. And in conclusion, a needs assessment rather than a diagnosis is the referral process that underpins access to specialist palliative care for people with dementia. However, there is little consensus on grey areas within the assessment process, and a defined model of care is needed for people living well with dementia in the community and support for families and caregivers.
Thank you so much for this overview. We have to close the session now. I also want to thank all participants, and there are still many, 58 for participating, and well, especially all the presenters for giving us an overview for specialist professionals and also a more general overview. And it's also important to highlight the function of palliative care. Thank you so much for joining. And well, you provided the email addresses. If there are questions, please post them. Thank you.